Thank you very much. Can you hear me all right? I'm going to assume yes, even though I'm not
Yes.
getting a response. Okay, great, thank you. So first of all, thank you very much for inviting me to this meeting, and I really am disappointed that I was not able to go in person. I know that meetings, that meetings are so much richer when you have people that you can talk to and exchange ideas. And I do hope that we get out of this situation soon. So thank you again. And I have gotten up pretty early to watch some of the presentations, and it's been a really exciting meeting so far. I apologize, I did not see the presentations this morning. I decided I was not going to be able to function if I had to get up at 5 a.m. again. So some of what I say, I'm sure you will already have heard, but I'm hoping that I can sometimes put a little bit of a new twist on it. And I've also learned that when you say something 3 times, that's when it sinks in. So hopefully by the end of this presentation, it'll be your 3rd and not 10th time hearing the same information. Okay, so now I'm trying to move the slide, which I just tested. Oh, okay, I see a thing on, okay. All right, so this is just a very brief overview of what I'll be talking about. A little bit about the changing landscape, which again, I think we've already talked about quite a bit. Some of the long-term health effects in vulnerable populations, and I'm going to really limit this because we heard a lot about the health effects of cannabis yesterday. A very brief review of the differences between the federal and state policies, and then I'll give you some examples of what we are seeing since legalization has gone into effect, particularly in Colorado, because there's a lot of very good data that have been coming out of there, since that's been tracked quite closely since legalization went into effect. And then some policy considerations to minimize harm. And I was really saddened to hear the last speaker talk about all of the policy regulations that have failed in Florida, because I think some of those are areas where I think there is the potential to have an impact. And I do think it's different in a place that doesn't have any sort of legalization first. So if there does seem to be some sort of movement in that direction, I think it's really important that the policies that are developed and the regulations that are developed early on are as conservative as possible, and with the potential to loosen up if it doesn't appear that they're causing a lot of harm. So I usually start with this slide mainly to make the point that cannabis is a complicated plant. It contains many different cannabinoids. And I would say that, similar to what has already been discussed by Bertha and others, while the medical marijuana discussion was a way of getting into this sort of the recreational marijuana market, and it was obviously quite an effective strategy. Another aspect of the strategy is sort of the way people obfuscate how they talk about cannabis and cannabinoids. So I've been at many hearings where the discussion is around medical marijuana, and the people who are brought to make the case are parents whose children have epilepsy. And the medical marijuana that they are talking about is really CBD, and it is not the same as what is mostly being sold in the medical marijuana dispensaries. And I think there's a purposefulness there, because showing, a 30-year-old who's using cannabis now for medical purposes, which is exactly the same plant that they were using for recreational purposes, does not make a compelling case. So I think we need to be careful in how we talk about these different products. Right now, we have actually 36 states that allow for medical use. And adult use is allowable in 18 states plus DC, and these numbers are constantly changing. And there are also, in some of these states, there's overlap, and I think you saw a little bit of it on the last speaker's slides, allow for what they call low THC products. And these are not necessarily hemp, which, as you may have already heard, hemp is cannabis that contains less than 0.3% THC, and it has been removed from the Controlled Substances Act, so it is no longer controlled that way. We know that there are ingredients in marijuana that have been approved as medications, and so I think this gets at one of the other other issues that we are having to contend with, which is that cannabis is very different from some of the other drugs that people are abusing. So tobacco and alcohol do not have any potential health effects, whereas cannabis or some of the ingredients in cannabis do, and some of them are known. And we have a similar problem with opioids, but each of these is a little bit different for different reasons. So I think you've probably already heard this in the United States. Past month, marijuana use has been increasing. We have not seen, this is a national survey, we've not seen increases in the 12 to 17-year-olds. We do see it in the 18 to 25-year-olds. And sort of disturbingly, we're also seeing it in those 26 and older. This is the way that this national survey breaks down its age ranges. But a lot of these increases are being seen in older Americans from the baby boomer and similar generation. Sorry. So what's even more concerning, and I think some of the national surveys are limited in the kinds of information they collect, but they do collect information on frequency of use, meaning daily or almost daily or some subset of that. And what's happened over time is that among the users, which have grown tremendously, as you can see, in 2002 there were only about 14.6 million users, while in 2019 there were 31.6 million. The number or the percentage who are using on a regular basis 20 or more days a month has also increased from about a third to about 40%. And of course, this is very concerning because we do know that, that more frequent use, and again, we're not even measuring with the sort of granularity that we probably should be to know, are these people using once a day? Are they using all day? Are they basically stoned for the entire day? We don't have that sort of information in these national surveys. What we do have in these national surveys are trend data so that we could measure some of these different effects, some of these different changes in use patterns, and also in the perception of harm, which has been going down in all of these, in all of the age groups. So there is, and again, we've been hearing about this, and I think that this really does still bear repeating. I mean, the cannabis products of today are not the cannabis products of the 80s and the 90s. What I'm showing you here is a project which is monitoring the amount of THC and CBD in products that are seized by the DEA. So this is the illegal market. This is not even the market in the dispensaries. And our understanding from dispensary products is that we're talking more around 15 to 20% in plants. And then, of course, there are concentrates that have much higher levels of THC. And as you've already seen many times, there are all of these other very appealing products that appeal to children and appeal even to very young children. And why do we care so much about this increasing potency? Again, we've heard about, this is the third time at least that you're seeing this slide, and the only reason I'm putting it up here is to say that some of the most adverse consequences of exposure to cannabis happen with people who are using frequently and who are using high potency products. And this is the incidence of psychotic disorders in 3 sites, London, Amsterdam, and Paris, showing that those people who use frequently have a much higher incidence of psychosis. And in fact, some of the new cases could in fact be prevented if people were not using these high potency cannabis products. We also know there's greater risk for addiction and for other sorts of adverse effects, including acute adverse effects, particularly from these very high concentrated products in people who are fairly naive users. So I don't have time to really go into this, but I did just want to make the point because I think it comes back to, when we're trying to think about the public health messages and the campaigns that we need to develop, we also need to think we need broad campaigns, but we also need to think about who are the sort of targeted groups that are most at risk. And I think our main, a lot of our concerns are about the long-term health consequences, which are in some cases a bit difficult to prove, with some exceptions, but I'll come back to that. But looking at this slide, you can see that many of our concerns are around exposure during fetal development or even perinatally, children and adolescents, and we've certainly heard about that quite a lot at this meeting, but also persons with mental illness. We know that cannabis can worsen mental illness, but there's a very high rate of comorbidity between mental illness and cannabis use disorders. And so in addition to the risk for psychosis, there are other risks as well. And this is another area where we do need to sort of focus our efforts in prevention. I put tobacco smokers here. There's not a lot of data yet, but there's a little bit of data suggesting that cannabis use may make it more difficult for tobacco smokers to quit smoking, and that would be a huge public health problem if that's the case. And older adults are really a big question mark. We know that it's being used. We know that it's being used even in a medical context to try and control agitation in some of illnesses that older adults have. And we don't really understand the full repercussions of that. We are obviously concerned about the cognitive effects, but then there are also effects of cannabis on coordination and movement. So there's the possibility of increasing the risk of falls. Many older adults are using multiple medications, and there's a possibility of interactions there. So it's really a population that is becoming more of a concern, and for which we have very few data. So I am going to focus just a little bit on the pregnancy aspect, because I didn't see that discussed very much, at least in the parts of this meeting that I was able to attend. And this is a large study that was done by Kaiser Permanente, which is one of the major health providers in the US. This is a study of almost 300,000 people, and it's looking over time. And what you can see is that overall, there's been an increase in marijuana use during pregnancy. This orange line shows people's self-report of use of cannabis during pregnancy. And the blue line shows those who have a positive toxicology result. And this is very important, because when we're trying to measure what's going on, I think we have to recognize that, especially in pregnant women, where there is definitely social stigma not to use any kinds of substances, there's also going to be a lot of underreporting. And I think this is true. And I think in all of our measures, we have to recognize that there are going to be social factors that determine how accurate they are. And for pregnant women, I think this would be particularly problematic. Also, when you look at it by age, these findings are probably not terribly surprising, but still they are concerning. Among pregnant women who are under 18, the rates of cannabis use are very high, 20 to 25%. Even in those 18 to 24, they are at around 15% or approaching 20%. And in pregnant women who are between 25 and 44, the numbers are a lot lower. Now, I will say that the national data on pregnant women using marijuana has shown some positive trends the last 2 years. There does seem to be a decrease, particularly in those using it regularly. But many of you may have seen there was an article that looked a few years ago in Colorado at a number of different dispensaries and whether or not they recommend cannabis to pregnant women. And in fact, they do. And they, most of them, the bud tenders are trained enough to know not to say that there's evidence for this, but they do say that my experience is that this can be helpful for nausea, that this can be helpful for anxiety or depression. And most of them were not even recommending that women talk to their physicians first. Now, Colorado, I think, became very alarmed at this and has done a lot of public health campaigns since then to try and counter it. But I think this sort of tells you that if we're not keeping our eye on sort of everything that's happening, there are many ways in which things can really go awry. In terms of what the impact of prenatal cannabis exposure is, we still, believe it or not, we still really do not know enough. We have several long-term studies that are following prenatal exposure over time. 2 of these started in the 70s and 80s. And so the products that people were using then were very different. The circumstances were very different. Even the idea of what was considered frequent marijuana use at that point was quite different than what it is now. Weekly was considered frequent marijuana use as opposed to daily or multiple times during the day. And the products that were available were quite different. And the two cohorts, one was in Canada, one was in Pittsburgh, came from different socioeconomic statuses, but the findings were quite consistent in these 2 studies. And now there is a 3rd cohort that's from Generation R. It's a study being done in Amsterdam, in which they have been following, these are children who were born between 2002 and 2005. So that's giving us a better idea of products that are being used more recently, although many of the women there use both tobacco and cannabis, so there is a bit of a confound there. But overall, the effects are that are consistent are those of lower birth weight and hyperarousal at birth, attention problems as these children are growing up, some lower scores in verbal and memory domains, and some evidence of externalizing behaviors, including attention deficit disorder and impulsivity, and as well as some delinquency. And if any of you heard Bertha yesterday, the ABCD study has shown that prenatal exposure may be associated with psychosis proneness in children at this age, even though we don't yet know whether or not they will go on to develop a psychotic disorder. And then as young adults, there are problems with executive function. Now, all of these findings have many, many caveats. There are always many confounders. The samples are becoming smaller as time goes on. We don't, this is not necessarily accounting for postnatal behavior, whether or not these women were breastfeeding, but nevertheless, the fact that you're getting even some consistency across time, and that consistency is also consistent with what we know about how cannabis works and where it works, still suggests to us that there's something important going on there. And this was, part of why the Surgeon General in the US a few years ago, Jerome Adams, issued an advisory warning women not to use cannabis and basically stating that no amount of cannabis has been shown to be safe during pregnancy. So what we know about prenatal cannabis exposure, and some of this is, I come back a little bit to what Bertha was talking about when we're thinking about causality. We have to think about it from different perspectives. Humans are messy creatures, and we cannot just say we're going to assign you to take in this much cannabis, and you randomly are assigned not to, and then we will measure the outcomes. So we're having to backtrack and figure out many of the factors that can contribute to outcomes that we're looking at. But we also know that the system that cannabis acts on, which is the endocannabinoid system, is quite important in development and during pregnancy. It's involved in implantation, placentation, fetal organ development outside of the brain development, including cell differentiation. So all of these are ways in which the endocannabinoid system can affect development. And we do know that THC crosses the placenta and can accumulate in fetal tissues, especially in brain, and it's also found in breast milk. There are human fetal imaging studies. Yasmin Hurd has done some of these studies in aborted fetuses and found that there are changes in the dopamine receptors in these fetuses of women who were using cannabis. And the dopamine system is important in reward and in stress responsivity and in many other functions. And some of these findings may in fact be sex dependent. Very clearly, prenatal cannabis exposure is linked to fetal growth restriction and to low birth weight. And the longitudinal studies, which I sort of very quickly summarized on the last slide, report subtle to modest impacts on cognition and neuropsychiatric outcomes in children, adolescents, and young adults. And preclinical studies as well, which are crucial for our being able to really understand the role of THC in brain development, or the impact of THC in development, also show lasting effects of THC exposure during this period on adult drug seeking, on stress responses, and on brain reward systems. But there are many research gaps, and again, this is a very important area of research. The findings are often modest. As I mentioned, there are many, many caveats to them, and there may be both mitigating factors as well as factors that worsen the outcomes. Results are not always consistent, and they may be confounded by other variables, prenatal nutrition, exposure to prenatal care, violence in the household. All of these may have important impacts on the outcomes and need to be measured in any cohort that we're following for prenatal exposure. So among the things that I think we really need to be focused on, or we need better measures of cannabis exposure, we probably need to focus more on biological measures versus self-report. We need to be looking carefully at the frequency and patterns of use. The timing of exposure, there usually are not, most of the studies don't have enough of a granularity to look at whether the exposure occurs during the first trimester or later on, prenatally or postnatally. It does seem that many women, when they find out that they're pregnant, stop using cannabis, and there may be different effects if you stop at the end of the first trimester. But many who continue to use cannabis are either using because they still do not think that there's any harm associated with it. They're still looking at it as a natural product, or because they have serious other types of comorbidities, including anxiety and depression, which they are using cannabis to try to help self-treat. Quantification of exposure to THC or other components is also something that we're lacking and may be very important. We need data from more recent cohorts that are using these different products, these high potency products that contain varying amounts of THC and CBD, or even CBD alone. We need to be looking at sex-dependent outcomes. There's some preliminary data that suggests that there are differences. Females tend to be a bit more sensitive to the effects of female infants tend to be more sensitive to the effects of exposure than males. And as we heard from Bob DuPont yesterday, polysubstance use, this is a tremendous confound, and really that is the norm these days. Most people who are using cannabis are also using other substances, and we need to be able to disentangle those effects or understand how they enhance each other or counter each other, as well as looking at the overall environment, the social environment, the socioeconomic environment. All of these can have very strong effects on what happens to children that develop. There's actually some interesting data from both the Gen-R study and from preclinical studies showing that paternal exposure may also be really important, and that THC may actually be capable of changing the sperm cells in long-lasting ways through changes in methylation, which can be carried on to the next generation. And again, we need more preclinical research where we can accurately control exposures, and we also need to have clinical research, including longitudinal studies. And I will shamelessly plug a new study that we are about to start, which is called HBCD, and it is going to be a large longitudinal study with about 7,500 mothers and infants being recruited, and it will be looking at brain development trajectories and behavior from birth through ages 9 to 10. And we're hoping that about half of this cohort will either have been, or a quarter of the cohort will have also been exposed to substances. This will include opioids, which is part of the reason for doing this study, but obviously cannabis is also being used and will also be very carefully measured, as well as other substances. And also we will have a comparable cohort that comes from similar social environments to be able to make better comparisons, as well as a more general cohort. So a number of different measures will be taken, both measures of brain development as well as detailed measures of the environment, biospecimens. And one of the things that we will do with the study, which we also do with our adolescent study, is that we will make the data widely available to the research community so that many people can take advantage of it and can use that to ask the sorts of questions that they're interested in. So I'm switching to adolescence, and I'm going to be really brief here because we've had a lot of discussion about this already. We know that the reason I like this study, which I think you've already seen, is because, again, coming back to what Bertha was talking about early on about how do we prove causality, this is a nice study because it shows a dose-response effect, and that's one way of suggesting that there really is a causal effect of cannabis use rather than it being a correlate of something that's associated with these adverse outcomes. And you can see that this is a study that combined people from 3 different cohorts, showing that the more frequently that people use before the age of 17, the greater their risk for adverse outcomes, particularly cannabis dependence, other illicit drug use, suicide attempts. And I'll come back to this. I think this is a really, really important finding that's coming out over and over again in a number of different studies, one of which you heard about in the last speaker. smaller chance of completing high school, of obtaining a college degree. Depression results have been sort of iffy. There may be an effect, but it seems to be relatively small. But welfare dependence is another one where there seems to be a lot of replication. There are many different people who are doing brain imaging studies. Many find differences in brain structure and function in youth who regularly use cannabis. These are generally before the age of 18 or 17. These are just two examples, one showing decreases in the axonal connections between certain brain areas, one of which is the hippocampus, which Madeline Meyer talked about yesterday as an area that is generally smaller in cannabis users. And another one is looking at functional connectivity between the prefrontal cortex and the nucleus accumbens, and showing that it's actually decreased in adolescents who have an escalating pattern of cannabis use. And this is important because the prefrontal cortex exerts some control over behavior, and the nucleus accumbens is your go mechanism, and the prefrontal cortex is a brake, if you will allow that extremely simplified connectivity, simplified cartoon. So we know that there are a number of risks in adolescence, and we've heard about them. Again, I just want to say that there's this biological plausibility. This endocannabinoid system is involved in brain development and myelination, which is one of the main things that happens during adolescence. There are human neuroimaging studies that can show that the cannabinoid receptor-rich brain areas are altered following exposure. Multiple studies, and we heard about some of these yesterday, indicate effects on learning, IQ, motivation, long-term outcomes, and preclinical exposures show the same sort of lasting effects of THC on adult behaviors. The caveats that we have to deal with are that many users who start young and use frequently may have other risk factors for adverse outcomes. A daily user at the age of 15 may be coming from a difficult home environment, may have genetic loading that leads to sort of this early drug use. These are always confounds that we have to think about and just make sure that they factor into the studies that we're doing as best we can. Adolescents who use cannabis regularly often use multiple substances, and we really don't know whether the effects persist when cannabis use is stopped. The information that Madeline Meyer showed yesterday indicated that among users who quit, there did seem to be a restoration of some functions, but not all. And those were users who were using for a long time in a very heavy manner. We don't know about adolescents who start using and then who quit. We don't know if adolescence is a critical time period, and once the changes happen, they are set, or whether or not it's a time of plasticity and resilience. So I think these are all important questions for us to know about in terms of our public health messaging and efforts. My second plug, this is the Adolescent Brain Cognitive Development Study. Dr. Bertha mentioned this yesterday. This is a large study to almost 12,000 children from the ages 10 to 20 years. The sites are all around the country. And again, it's looking in a very detailed manner at brain development and at a whole host of other measures. We initially started thinking about this study because of the changing laws around marijuana and the fact that we were always in this position of saying, well, we've seen that marijuana causes these changes, but we don't know what these children look like before they started using. So that's why we were starting at ages 9 and 10, before most people have been exposed to substances, and then following them over time. Study is much more detailed than that. We're looking at mental health, we're looking at physical activity, screen time, all of these various things. But we're hoping that with such a large cohort, we'll be able to start to determine what the role is of different substances on brain development, on substances in collaboration, as well as different quantities, or even people starting and then stopping using. And again, these data are being made available every year so that people who are interested in doing the research on them can. And one of the studies that Bertha mentioned about looking at the effects of prenatal exposure to cannabis, showing that there may be an increase in psychosis proneness, was based on data from this study. So switching to policy, which is really what I'm supposed to be talking about here, is, again, and a lot of this you've already heard. We know that policy is not based on science. We know that it's based on many factors. The U.S. public opinion has been changing dramatically. Now, only fewer than 10% of U.S. adults say marijuana should not be legal at all. Note that these surveys are not very nuanced, so they're not really giving people a choice of, do you think it should be legal or it should be, they're asking, should it be legal or not, or legal for medical or not, and they're not really giving the other possibilities that fall within that realm. So I think that a lot of public opinion is driven by the social equity and the criminal justice issues that are very clear, that have disproportionately affected people of color. And so trying to somehow rectify that by getting this out of the criminal justice system. And then a lot of it is based on, what people remember from their times of using marijuana. And then finally, and you heard this beautifully presented in the last talk, the media. I can't even think of any sort of movie or TV show which portrays marijuana use as bad. It's always funny, people are stupid, they're not, but they're not showing, even with alcohol, which obviously comes up a lot in movies, there are still movies or TV shows or other forms of media that show what can happen when you become an alcoholic and how it can destroy your family and how hard it could be to stop using. But we don't see any of that for marijuana. And I think that, we really are fighting a very difficult battle when all of this media is kind of pushing in one direction for many reasons, including the economic reasons that we've heard about. And of course, we would like science to be part of this discussion, and that is kind of what my institute does. We try to try to bring the science out there so that people are at least aware of what we know and what the risks are. So U.S. federal policy is that marijuana is still at Schedule 1 under the Controlled Substances Act. This goes along with the Single Convention on Narcotics, which is an international treaty. It's illegal. Each nation can designate a single source of marijuana for many years, actually until this year. The DEA, the Drug Enforcement Agency, only licensed a single grower, which was the University of Mississippi, and NIDA had the contract that was supporting this, and NIDA was responsible for distributing all of the marijuana to researchers who were interested in doing studies on this. And I think that, the University of Mississippi has tried to diversify its products and make different things available based on researchers' interests, but we don't have nearly the diversity of what is available in dispensaries and really everywhere. And so we're actually quite excited that there will be additional growers. They've just been approved. This has taken an extremely long time, and hopefully they will get started soon, and that will allow for a greater range of products to be studied so that we can learn more about the effects. We're still not able to use products from dispensaries in our research because it's still illegal on a federal basis for the states to have these dispensaries. That's another story. Also, I just wanted to mention again, hemp is cannabis with less than 0.3% THC, and it is not controlled under the Controlled Substances Act. There are bodies that are responsible for regulating it. The Department of Agriculture is responsible for growing. Product quality and labeling is being managed by the FDA, but right now the FDA has really not taken a very active role. They're still collecting data, and this is very problematic. As again, I think you heard a little bit about CBDs everywhere, and the products that are available are not being regulated and may contain THC or other things that are not on the label. And then people are, and as always, there seem to be people find ways around these laws, and there are now products that are being derived from hemp that have abuse potential, like Delta-8 THC. And Delta-8 right now is in a very murky legal status. So you've seen these maps. Just one quick point here. This is what the country looked like in 2015. There were only a few states that had done adult use or recreational use and medical use. There were quite a number of states that had medical use, and then there were these states that had CBD only, which were really sort of low THC products. They weren't even necessarily falling within the definition of hemp, since hemp was not defined at that time. And here's where we are now. You can see that the entire map is covered almost There are only 3 states in which there are no legalization policies in place. There are still a number of states that only allow for low THC products, but overall, most states allow for broad medical use, and now we have many, many states that also allow for adult use. Because this is happening on a state-by-state basis, the regulations are quite different. States that have medical marijuana laws, some of them have, they have different conditions that they allow people to be using these, or different routes of administration. Some are more restrictive, some are not. Many of them allow sort of any condition for which a doctor thinks it could be helpful. Some of them have dispensaries and home growth, some of them don't, some have registries. And the testing and regulatory requirements, because there's no federal oversight, states are trying to do this. I mean, they are trying to regulate these things, but there are but there are many different private testing companies that don't necessarily provide consistent results if you go to more than one of them. States with the adult use laws also vary on the types of marketing that are allowed, what kinds of product labeling is required, how they're being distributed, whether there can be home growth. In some cases, in California, there's delivery. Public consumption. This was a big thing for a while, and again, it's just amazing. It really got turned into a social equity issue that because public consumption was not allowed, that meant, and because people who lived in apartment buildings generally were prohibited from using marijuana if the people that own those apartment buildings prohibited it. So that meant that only those people who own their own houses would be able to be using marijuana in their homes, and that created a disparity. And so therefore there was a lot of discussion of, well, what is a reasonable way of dealing with this public consumption? So everything gets twisted and turned, and I think, and again, you've heard a lot about why that is, and you'll hear a lot more from Kevin Sabet as well. Types of taxation and what the money is being used for, how licenses are being given. And then many of the states are working on expungement and equity. And I do think that's really important, because there are a lot of people that have criminal records or are in prison for things that they related to marijuana that they should not be. What is the impact of legalization? Well, we've heard a lot about all the various things that we're worried about. I'm going to show you some data from this HIDA report, because they've been doing research every single year since Colorado passed recreational laws. HIDA is the High Intensity Drug Trafficking Area group, which is sponsored by the Office of National Drug Control Policy, and they use data from a variety of different national and local surveys. I put in this slide because I saw that Carlton had it, and I actually took the same picture in New York many years ago, and this was pre-COVID. And, again, I saw this on the street and thought, well, this is odd since I know it's not legal here. But what I really thought was quite amazing was sort of the next morning, I took a walk very early in the morning, and this is what I saw. So I just felt like a picture tells 1,000 words here. And this was just sort of amazing to me. This is, again, before COVID. So even though there aren't a lot of people on the street, there will be very shortly. Again, I talked about the fact that marijuana is increasing in adults and young adults, and I would say that that's even true in states like Colorado, where we're not seeing increases in youth ages 12 to 17. But what we do see, and what you saw again yesterday was presented, was that the states that have recreational laws or medical laws also have higher rates of use, and these are higher than those states that don't have those laws. Rates are going up in the 18 to 25-year-olds and in the 26-year-olds. And there is a study that showed that increases in cannabis use disorder were being seen in those ages 12 to 17. So it seems that those who are using within that age group may be using more frequently, or maybe higher risk users. Again, compared to national data, so overall the numbers have been going up, and they've been going up. They took a big jump up when adult legalization went into effect. This commercialization has to do with medical use, which was allowed for many years before 2010. But in 2010, there were some Justice Department memos that basically said that the federal government would not be going after people in states where it was legal, provided they didn't overstep certain boundaries like sell to youth, et cetera. So commercialization actually produced a bit of a jump in use, but then legalization produced an even bigger jump in use. And you can see this is compared to the rest of the country. And then if you just look at the 12 to 17-year-olds, once again, I do point this out because I think that this doesn't mean that they're not being influenced, and it doesn't mean that all of those messages that you just heard about are not sinking in, and that these children are not going to use. But we have not seen the large increases that we were anticipating and very worried about in Colorado when legalization went into effect. I will say that during COVID, sales went up by about 40%, and partly because cannabis sales were considered an essential service. And as you heard, people were able to both get delivery or get curbside pickup. And also college students really went up in their use of cannabis and daily cannabis use, which is very concerning. There's a study that's been looking at those in that college age group. Those who are not in college always had higher rates of use of cannabis than those who were in college, but now those who were in college actually caught up to them, while drinking did not go up at the same rate. ED hospitalization rates, and again, I do want to just mention that these are rates, and I think it's important that we keep in mind the rates, because what's also happened in Colorado is the population has grown significantly. So if we just look at numbers, we're not necessarily going to be getting the full picture because of the fact that the denominator has changed. There are now more people living there. So those haven't gone up tremendously. The numbers of youth between the ages of 0 and 12 that have come into the emergency department have gone up, and usually those are in relation to edible products. And treatment overall has gone down in Colorado, but if you look at it for marijuana, but if you look at it by age group, again, it's the 26 and older that are getting into more treatment. So again, this is why I think we need to have more information on this age group, and particularly on those maybe ages 65 and older. And coming back to suicide, because it's really horrible and devastating, and I just wanted to again point this out. This is a slide that I got from Laura Stack. She runs a group called Johnny's Ambassadors. Her son died of suicide, and he was dabbing. But what the data that she sent me from Colorado were showing the rate of suicide among youth ages 15 to 19 in Colorado. And you can see that there was this sort of big jump up here in 2015. And if you look at the toxicology reports, this is the same time that that marijuana being detected in their toxicology also went up, whereas alcohol did not. So I think there's something very real here about suicide, and as was also mentioned, that it's not always in the context of depression, but there seems to be something, and it may have to do in part with psychosis, but there may be other factors as well that we just don't understand. So regulations matter, particularly if they are enforced. I'm going to come back to this regulatory scheme in the next slide. But there are ways of trying to limit harms by determining what products can be made available, what the serving sizes are, and whether there are potency limits. The commercialization model in the U.S. has fought all of this, tooth and nail, and in some cases, Colorado had. When they first put edibles out, they had a lot of people wound up in the emergency room as people got a bit more sophisticated about it going on, but they tried to pull back on the edibles and were unable to do that. There can be marketing restrictions. You can't control all of the social media. That is really unfortunate. Certainly labeling requirements. All the states now have labeling requirements that they have so that their cannabis products are marked. Product testing and allowable ingredients. There's some of them, we had a problem with vaping products a couple of years ago with this E-Valley, which was something that turned out to be mostly vaping products that contain THC, but it wasn't THC, it was other products that were in the vaping liquid that caused the problem. And again, these are not regulated. Smoke-free laws are really critical. And again, we keep hearing that the cannabis industry is perceived differently. We have all of these influencers who are pushing it.
and even smoke-free laws, which should be obvious. The smoke that's produced by cannabis is not different than the smoke that's produced by tobacco, and yet not all places have smoke-free laws that apply to all cannabis products. Consumption sites, again, this is something that a lot of states have been struggling with. While initially they were trying to not have them at all, some of them have made concessions now because of some of the equity issues. The types of licensing requirements, how much taxes and where does the money go? Taxes are tricky because you want them to be sufficient to be able to get some revenue, given that there are also costs, but at the same time, there's a black market that you can't go, if you go too high, then you're going to be competing with the black market and the black market is going to win. And again, social equity, I think, is another really important aspect of what's going on in the states that are legalizing it. But what is really important here is also who is making these decisions. Almost all of the state regulatory boards have industry on those boards. You would never do that if it was tobacco. So this is what I meant about sort of different implementation strategies. This is a report that the Rand Corporation did for Vermont before they were going to legalize. And they were just talking about different approaches. We tend to either go with prohibition or we go with the standard commercial model, which is where we are in the US, where basically there's anything goes and the profit motive is what is driving, the industry. But there are other ways to handle this that would be perhaps less dramatic and perhaps less harmful. There could be, you could decrease the sanctions and get rid of the criminal penalties. You could only allow people to grow their own. The Dutch model, which has not necessarily resulted in, a great increase in use. You can have the government operate the whole supply chain, communal own growth. You can even have nonprofit organizations running this so that the profit motive is taken out of it. But very few, or have very few monitored licensees. So there are different alternatives that can be implemented if countries are going down this route that would not necessarily have all of the implications that the U.S. model has had, which is commercialization in almost all of the states. And again, commercialization means it's for profit. For profit means you want to get a lot of heavy users and addicted users. If you want to get a lot of people who are using heavily and become addicted, you want to target young people. We know that they are most vulnerable. As they start young, then they have the greatest risk of going on to develop addiction. And so what's happened, given our particular model, this is just a study by Rosalie Pakula, which looked at what people were allowed to purchase in states that had legal cannabis. And what you can see is that she broke it up into 10 milligram doses per transaction. And you can see that even a single purchase in Michigan, you could buy something like 2,200 doses. So states allow a very large quantities of THC to be purchased, larger than what is typically consumed by daily users in a month. And so this is one way in which you may wind up getting a significant amount of diversion. And again, it's another regulatory lever that states could use, but they are really not doing that at this point. The other point I wanted to make has to do with this medical versus adult use product. And essentially, they are the same. Now, I'm not going to say that, there are medical users who are very serious and who are really looking for mostly cannabidiol or only cannabidiol products, which are certainly growing in their, it's a multi-billion-dollar industry now in the US, but many of the dispensaries that contain cannabis products, most of the products that they are selling as medical products are not any different than the products that they are selling for recreational reasons. And I bring this up for two reasons. One, because when people are talking about medical cannabis, if they're not in the, there are different things that are happening in different countries. But in the US, most medical cannabis is not any different than recreational cannabis. Some is, there are people who are very serious about trying to find products that are better for medical purposes. There are all sorts of ways that people can take these products. There are tinctures, there are high CBD tinctures, but the great majority of sales through these dispensaries and other ways are products that are the same, whether they are medical or recreational. The other point I want to make is that the studies that did look at the cannabis plant, and these kind of go way back for medical purposes, in pain, for example, used products that were much lower potency. They used products that were maybe 3 to 5% THC. And so the medical benefits that were shown, even in the limited research that's been done, were not with these 20 high potency products. And their impact on many of the things that we are concerned about may be much different than these products. So again, there is this sort of obfuscation of, what is medical cannabis? And well, there are studies showing that cannabis can be useful against pain, but those studies are looking again at much lower products, and they are still limited, or they are about specific ingredients within the cannabis plant. And again, coming back to this whole secondhand smoke, it seems like we're somehow litigating that again, that secondhand smoke has not been proven to do all of the things that secondhand tobacco smoke has, but really there's no reason at all to believe that secondhand smoke is not equally damaging from cannabis as from tobacco. So we at NIDA, we had a work group that we asked to give us some ideas about policy priority, research priorities for policy. And I think that many of these we have already been discussed, even if not by me, by others. But we do need improved measures of frequency, of exposure dose, of patterns of use. I think this was something that Bob DuPont talked about and was encouraged about yesterday, about point of contact measures of impairment alone and in combination with other substances. This has been really challenging because of the pharmacokinetics of THC and tolerance and all of the other issues that Bob talked about yesterday. But he was encouraged by the idea of having oral fluid measurements that might be a better indication of recent use and might help with our being able to detect this and then, in fact, find a way of stopping people from using while they are driving or doing other behaviors that could be dangerous. The impact of the changing potencies, constituents, and alternative routes of administration on both health and safety outcomes. One of the other arguments that's been made is that legalization alters the use of other substances and that alcohol is worse than marijuana, which it is in some ways and it isn't in other ways. But so far, there's no real evidence that alcohol use is going down, at least in the states that are measuring sales. Alcohol sales are at least as high as they were when THC was made legal, and in some cases they've also been going up. And again, the impact on tobacco cessation. Again, the fact that all of these laws are changing, they're changing rapidly, but the social norms, I think, are really crucial. And again, we heard a whole lot about that. The social norms have changed dramatically. We have all of these influencers that are really trying to do that, that are making an impact and that are making money as they're doing this. And we have to really try to better understand how can we revert that? How can we, why are tobacco companies considered pariahs and cannabis companies considered our friends? Effects of second and third hand smoke exposure on non-users, including in utero. And we really need to come up with very persuasive public health campaigns, especially for people who we think of as being particularly vulnerable, to counteract the trend of decreasing harm perception. So how can science inform policy? We have to recognize that this is an extremely polarized issue, and we have to be unbiased in our discussion. And I think I want to come back to the first speaker that I heard. I think I missed the very earliest speaker. But we need to be thinking correctly about this, and we also need to be unbiased. We need to be explicit about what we know, what we think, and what we don't know. As a Fed, I know that we have lost a lot of credibility with many audiences. We are the purveyors of reefer madness, and I try when I do presentations to different people to point out both what the data do show and what are the gaps and what are the limitations in what we can say, especially about long-term effects and causality. We also need research to answer real-world questions. We need to know exactly what the effect is on the opioid epidemic. I think you heard Bertha that people who use cannabis are actually more likely to develop an opioid use disorder. But there's also the other side of that, which is that what about people who are using cannabis specifically to treat pain and are claiming that they are reducing the opioids that they are using. And there's a lot of anecdote. There's not a lot of data, and I think that's a slightly different question than what Bertha was talking about. And it's one. I mean, we know we have a lot of. Again, we have biological plausibility that THC can interact with pain systems and can interact with the opioid system, and it could be that it can really allow patients to lower the dose of opioids to get a similar pain effect. We need to know that. And under what circumstances? Is there a potency limit that should be imposed? And if it is, and if so, what should that be? You know, people talk about titration, and experienced users may be able to titrate the amount that they take in when they are smoking a product, for example. But new users are getting exposed to much higher potency products and are at much greater risk of initial adverse events or even subsequent adverse events. But also, there are products out there like these dabs that are 90% THC. I don't really know how you titrate those products. Should certain products just be prohibited? And again, how dangerous is prenatal exposure? We know that it's not a good idea, that anybody who's pregnant should be absolutely cautious and give their baby the best chance to have a healthy brain and a healthy life. But really, how dangerous is it? And there's so many people that are using now, and we really need to understand what is the impact of that. So we need to be precise in how we talk about it. We need to distinguish cannabis, the plant, from cannabinoids, plant-derived or synthetic, cannabidiol, and other medicinal preparations. And we need to ensure that the public health interests are front and center when regulations are being developed, and not the industry. And again, we need to better disseminate the knowledge that we have. And this is my last slide. And I again stole something else from Carlton Hall, who stole it from Martin Luther King. This fierce urgencies of now, which I thought was a really interesting phrase, because I feel like that's exactly where we are. We have policy that is just running away like a freight train, and we don't have the research, and we can't just say, stop, let us get the research, and then we'll go on from there. We have to be keeping up in some way, and we do know enough now to at least understand what some of the biggest risks are, and we need to make sure that that information is getting out there. And again, we know that there are risks that happen while a person is intoxicated. We know that the high potency products can have particular risks, chronic use as well, and particularly in certain populations. Hyperemesis syndrome, I didn't mention that earlier. I think it was mentioned already, but that was something, that's this cyclical vomiting syndrome, which is very painful, associated with stomach cramps. And right now, people take very hot showers to try to subdue the symptoms, but really the only way to get rid of the problem is to stop using cannabis. But this is something that we really weren't even aware of before all of this started to happen. So again, there are going to be other things that are going to come out because of the products that are available now, and because of the ways in which people are using them. And I will end there and take any questions.